welcome. My name is Shirel, and I'm a Future Foundation HoFH Patient Ambassador and the project lead on HoFH Awareness Day. And I am thrilled to be moderating today's webinar and kicking off the first episode of our webinar trilogy. Before we dive in, I'd like to go over a few quick housekeeping notes. So this webinar is being recorded and will be made available on HoFH Europe Foundation YouTube channel. If you have any questions, please post them in the Q&A box, and we will try to answer as much as possible live. And we kindly ask you to avoid posting questions related to your personal health records. We would also love to hear from you, so please let us know in the chat where you're joining from. It's always wonderful to see how global our community is. So today marks the first episode of the HoFH 360 Degrees, A New Hope for Every Generation trilogy. It's an educational series forming part of our HoFH Awareness Day campaign, which we celebrated earlier this month on May 4th. And this series offers a deep dive into the HoFH journey from birth to adulthood. And each episode focuses on a different life stage, bringing together patients, caregivers, healthcare professionals, and researchers to share insights, challenges, and progress in care. So today we explore the first episode. We'll hear from global experts and our inspiring ambassadors. So whether you're planning a family and you live with FH, already raising a family, or supporting someone who is, this conversation is for you. And it's everything future parents with FH need to know. So we are joined today by an amazing panel. And I'd like to introduce you to this panel, Dr. Julia Brandt, researcher and practitioner specializing in FH patient care from Germany. Luke Elias, caregiver and HoFH ambassador from Australia. And Professor Thomas Freiberger, head of the Molecular Genetics Laboratory at the Center for Cardiovascular Surgery and Transplantation in Brno, Czech Republic. And Miranda de Graaf, caregiver and HoFH ambassador from the Netherlands. Now, before we hear from our speakers, I'd like to begin by sharing a short story. So there was a young couple who knew very little about their own cholesterol. They had never heard of FH and had no reason to think they carried anything that might impact their future children and their future family. They were healthy, they were young, and they were fit. So they got married, and a few years later, they had their first baby, a perfectly healthy little boy. Their pregnancy was smooth, and the baby thrived, and life felt very normal. 4 years later, they decided to try for a second child, and the mom carried that baby with the same love and hope as her first. So soon after her birth, she noticed something different. She noticed tiny yellow bumps appeared on the baby's skin. Most wouldn't have thought much about it, but to her, they were unsettling. So she remembered a distant cousin who had similar skin bumps and passed away young of a heart attack. And no one had ever talked about a diagnosis or named the condition, but the story stayed with her, and that memory and this mother's intuition drove her to act. So she insisted on a full blood panel for her newborn, cholesterol included. When the results came back, they were shocking, and her baby's cholesterol was sky high. So she kept pushing for answers. And finally, after a while, the diagnosis came, and this baby was diagnosed with HoFH. And this diagnosis changed everything. Then 2 years later, when she had a third child, a son, she was no longer in the dark. She knew what HoFH was, and she knew that it was rare. But what she didn't expect was that it would strike twice in the same family. So her son, too, was diagnosed with HoFH. What began as an unknown and invisible risk had suddenly shaped the future of her entire family. So that story and that journey was my mother's story. It was an early diagnosis that really saved me and my brother. and it was only possible because of my mother's intuition and her persistence. But sadly, many families still don't know about FH, still don't know how important testing can be, especially in children and babies with high cholesterol. And so, to help us understand better this, I'm honored now to bring in Julia. So, Julia is someone who runs a lipid clinic and regularly meets patients with FH or very high cholesterol, including many families planning a family. How do you approach those conversations, and what do you think families should be considering when it comes to early testing and diagnosis?
Hi, Shiraz. Thank you. Thank you very much for the kind introduction, and hi, everyone on the screen. So, yes, to be honest, it was very fitting. So I just today had a 30-year-old patient with heterozygous FH, and he was exactly on the point where what we are currently discussing. So he wants to set up a family. And so, to be honest, I ran through my slides with him that I prepared for the meeting today. So let me share those with you, and then we can better discuss if you allow. So, what I want to talk to you about is family planning and what we need to know. And this is not only addressing those who are affected with FH, but also to the clinicians. And yes, it's a very short form of this, but bear with me. So, I think the most important point to understand for clinicians and families is that FH is passed down within the family. So, it's not only one individual that is affected, but it can be a whole family, or it is a whole family. And therefore, as it is inherited in a perfect world, what would we do? So, if we know that one partner has FH, then it is very reasonable and recommended to test the other partner to assess the genetic risk. Because if only one partner has FH, then each child of this one parent has a 50% chance to also get heterozygous FH. However, if both parents have FH, then the odds for having a child that is affected by a pathologic variant is even higher. So they still have a 50% chance of getting a child with heterozygous FH, but there's a 25% chance of getting a child with homozygous FH, as we just heard in your story. So, and therefore, then we really need prenatal counseling, or we don't need, but we should use prenatal counseling. And the most important thing is to understand how the condition is inherited and what we can do to then, if it is given on to the child, what can we do? What is the risk for the child? What is the risk for the family? So the parents can make an informed decision. I think that is very important. So when we have someone in the preconception stage, so a patient with FH, this is now much more regarding the women with FH, because they have to be extra careful. If the father has FH, of course, we have to manage his LDL levels pre-pregnancy, through pregnancy, after pregnancy, because every child deserves a healthy parent. But for the women, we have to take special care and special treatment because they are the ones carrying the child, of course, and taking the tablets. So let me run you through what we are thinking would be the correct way to treat a woman before conceiving a child. So, and firstly, and this is very important for everyone with FH, but for women pre-pregnancy especially, to optimize LDL cholesterol levels. Why? Because on the one hand, it decreases the mother's risk of atherosclerotic events or cardiovascular events before. Secondly, the mother has to pause her medication for a certain extent of time, minimum through the pregnancy, but maybe also through breastfeeding. So there will be a time within the mother's life, if she has FH, where she's not allowed to take her or only in very limited ways allowed to take her medication, so that then increases her risk. And thirdly, there are some studies that show if LDL levels are especially high in the woman, also before conceiving, this then sets up the child for increased risk of, again, atherosclerosis. So optimizing LDL levels means using lipid-lowering therapy. But if you use lipid-lowering therapy as a woman, then you should use contraception, because there is the issue or the debate about whether some of the lipid-lowering therapies we are currently using have some non-beneficial effects on the child. So you don't want to conceive a child while you're taking lipid-lowering therapies. Thirdly, to assess whether how far along the mother already is on her journey, if she has established, for example, coronary artery disease or whatever, mothers should visit a cardiologist before or when they are within the family planning stage to assess how far along on a disease scale they are. Is there something we can enhance to reduce or to mitigate their cardiovascular risk and probable events, especially during the time where they are not on any lipid-lowering medication? So this is the next step. 1 to 3 months before conception, it is recommended to discontinue all the lipid-lowering medication because we only have limited safety data. But I don't want to make anyone nervous. So if you're taking any lipid-lowering therapy and you become pregnant by accident, this does not mean your child is hurt. We just have not enough safety data to really, as a clinician or a doctor, as a scientist, say, okay, go ahead, take it, it will be okay. Okay, I think this is very important to understand. And then there is the debate regarding prenatal or pre-implantation genetic testing. You can do it. It is recommended, especially if both parents have FH. So the risk for conceiving a child with homozygous FH is especially high. But what is much more important, that the parents have an informed decision or come to an informed decision. And if they do, then we as clinicians, we have to respect this. I think this is a very important point here. So during pregnancy, then what are we doing regarding the LDL-C management? So we just discussed we have to pause the statins, the ezetimibe, the PCSK9 inhibitors. They are not recommended during pregnancy. However, there are exceptions to this rule. Some patients, especially with homozygous FH, so some women with homozygous FH, under expert guidance, they may be allowed, together with their clinician or their treating team, in the later trimesters of the pregnancy to go back on lipid-lowering therapy. Lipoprotein apheresis is something that can also be used in the severe cases like HoFH to control LDL cholesterol better during pregnancy. And then some also recommend to switch to bile acid sequestrants. However, they are often or very rarely well tolerated. Whether you treat or not treat during pregnancy, still LDL cholesterol levels should be monitored, and don't freak out if you see your LDL levels are rising, because this is a biological phenomenon. We see that up to 40% LDL increases during pregnancy. And I think the most important point is that you do not only refer to one specialist during a pregnancy. You should have your lipidologist, your cardiologist, your OB, and in a perfect world, you should also, if the healthcare allows or the healthcare resources allow, then you should also have a geneticist at hand who can then afterwards see whether we should test the child. So postpartum and during the breastfeeding, what do we have to remember? most lipid-lowering therapies should not be taken during breastfeeding. Again, just because of the limited safety data. Especially statins and ezetimibe are generally not recommended. And this is the reason why some patients, especially in those regions of the world that are a bit more wealthy, have a bit higher health systems, they may shorten breastfeeding just for the mother to resume the therapy earlier. So, and then we have to plan ahead, and then we have to screen the newborn. We have to screen the newborn always if one or both parents have FH. And then again, it depends on the region we're living in, whether this screening is done by an LDL cholesterol screening. But again, in a perfect world, we would do a genetic screening. So my take home, I put it two different ways, one for the clinicians, one for patients and families. So I think for us clinicians, it is very important to know we have to empower our families, and we can only do this if we educate them. We have to have a network of different specialties, and we are the ones that have to coordinate this care. And if parents come to a decision, we have to support this by information, but we should not always negotiate about what they decide. And for the patients and the families, I just want you to remember that FH is an inherited condition, so it runs in the family. Please talk to your doctor early if you think about family planning. Some medications aren't safe during pregnancy, and the genetic testing, if available, can help to protect you also your children's heart health. And I think what is equally important for both clinicians and patients and families is that we are not alone. Okay, we have to have a care team, and as it is a very rare condition, even though it is the most common of the rare conditions, you as a specialist only have a certain limited knowledge. So it's not only you that should be treating the patient, but there really should be a network. Okay. So, and I think this is what I want to get along to you guys.
Thank you so much, Julia. That was really insightful and really interesting. And I think we'll hear more from planning a family with HoFH in our third webinar. So please stay tuned for that as well. Now that we've heard the medical and the professional sides, so what about the lived experience? And here I want to ask Luke to join and if you could tell us, I appreciate that you join us from Australia and it's now 1 a.m. So thank you so much for your dedication and commitment. So Luke, could you tell us about your journey? What was it like to learn that FH was in your family and were you aware of it when planning yours?
Thanks, Sherelle. And yeah, welcome from the Gold Coast in Australia. It's gone 1 a.m. and very happy and very excited to join this forum. Julia mentioned a 30-year-old walking into her clinic, and Cheryl, you talked about a mum's intuition in persistence and continuing to find out when things didn't seem normal. And my story, uncannily, is exactly the same. When I was a fit and well 30-year-old, this was back in 2008. I was boxing, I was playing rugby, I was training 6 nights a week. I had a six-pack. Everything was going well. We had the birth of our first daughter, Evelyn, and my wife encouraged me as a new father to get a health check. So I went to my general practitioner, my family doctor, and had a blood test. I'd never had a blood test before then, and my cholesterol came back at 7.0, or around about 280 in the milligrams per deciliter scale. I was told that diet and exercise and some low-level cholesterol tablets, some statin therapy was a first-line measurement, a first-line intervention. I went on a very, very, even though I thought I was on a health kick before, I went on a zero-fat diet, was running every night. I went back in about 2 months' time and had my cholesterol retested, and it was about 8.0. That's when my tablets started, and if we fast forward, I was very stable after the tablets, just low-level doses of cholesterol, and my numbers came back down to what I understood at the time was normal levels. My wife was always, her cholesterol was just on the borderline of normal and elevated against the Australian guideline. So we both were never aware that we had FH. We just thought we had high cholesterol that was managed by low-level tablets. If we fast forward 6 years to 2014, we were blessed with another two children, Matthew and William. And when my young son William was 2 years of age, my wife noticed when she looked in his eye, the white in his eye was not quite white. There was a little bit of grey in it. She did not think it looked right. My job at the time, I was working, managing and running hospitals and health services in Sydney, Australia. And I was fortunate to know a lot of specialists and different folks. And we had a pediatric ophthalmologist have a look at my son's eye. And he told us it could have been a number of different things. One of those could have been a fatty deposit caused by cholesterol. So when we had his first blood test, the young son, the middle son, Matthew, had absolutely no symptoms, fit, healthy child, running around, developmental milestones all met. But young William at 2 just had this little marking in his eye, otherwise well. And his cholesterol came back, his LDL cholesterol came back from this blood test at 21. So in the other scale, it was pushing close to 800. They first thought it was an error. Then they retested. They tested all of our family, and my second son, his cholesterol was 23, the LDL cholesterol, and the daughter's was 3.0. So we went from being a family where there were two parents with mild cholesterol, well controlled with low level therapy, to now both being potential FH carriers with children that had complex heterozygous FH or HoFH. So these terms I did not know a lot about, even though I worked in health and the health industry. And I think when I look back at my journey, when I look back at finding out that my children were HoFH children, I think about what would I have told my younger self 16 years ago when I first had my diagnosis, and what would I have told my younger self 10 years ago when I found out I had two young children with something that I did not know a lot about. I was told it was extremely rare, and I was given some education about possible journeys, pathways of care that would be available and options for my children at that time. I break it down to probably two main lessons. The first lesson is that this is a marathon. When I think about my emotional journey, and sometimes when I was upset or stressed or uncertain or anxious, the first thing I would have told myself is this is a marathon and it cannot be run at a sprint pace. You really must rely on those around you, must rely on and Julia, you talked about you are not alone and there is a care team. And I think that's probably one of the most important pieces of advice that I would have given my younger self, is that there are people around and people who can help and support you. And this cannot be done at full pace every day of your life. Different therapies, different interventions take different time to work. Everything is not for everyone. There is not a playbook. It is not a simple formula. And what works for one person will work for the other. I've seen even differences within my own two children who both have the same genetic markers and the same health challenges living in the same environment. They've responded differently to different types of care and different approaches to help them live healthier, longer quality lives. That would be the first thing I would say, but it can't be done full pace, and you do have a team of support around you. The second thing when I look back would be that there are many different options, and that there is absolutely not a one-size-fits-all approach, and that the changes and the advancements that have happened in 10 years since my children started therapy have been absolutely amazing. And I think about, if I knew what the options were now, 10 years on, my fear, my uncertainty would not have been there. And I look forward with great hope over the next 10 years as networks come together, people share ideas, they support and advocate. No one could have done this 10 years ago because before COVID, our country, Zoom was used by 2% of businesses and everyone was scared to connect and the world was a bigger place. And I feel like with connections, positivity and support through networks and advocacy, it has just meant that I absolutely, going back to that first point, am not alone because I feel like there are so many more options 10 years on. And I would have told my younger self and my young family that we will be okay. And in 10 years' time, I look forward with great joy and excitement about what options will be available. And they are the things that have probably given me the most joy and comfort going through this journey. So I thank you for having the time, and I'm happy to hang around for the Q&A and hopefully share some more insights and reflections. So thank you so much for having me on this meeting, Cheryl.
Thank you. Thank you so much, Luke, and for being unwilling to share your story, because sharing your own story can really not just raise awareness, but also, as you said, give hope for others, and they're not alone, and there's a support and community for them. So thank you so much, Luke. And to help us, take a step back and look at the science behind this, I'd like to bring in Thomas now. Thomas, could you explain to us what exactly is HoFH and how does it differ from the more common heterozygous form and how we can diagnose it early? And we know also that you and your team are working on an exciting pilot project screening for FH. So could you also share a bit about that with us?
Yeah, thank you, Cheryl, and thank you all, guys. These were very touching stories from you and from Luke, and very great contribution from Julia. I'm happy to be here with you, and it's my pleasure to tell about genetics of homozygous familial hypercholesterolemia. Let me show my screen. I've prepared some slides for you. So I would like to emphasize what has already been said. FH is a genetic disease. So high LDL cholesterol is inherited. And you can see here on the vertical axis, cumulative dose of LDL cholesterol. It is a total burden of LDL cholesterol throughout the whole life. So not only it is important, the current level of LDL cholesterol, but long-term burden. And you can see this green, virtual green line, which represents a kind of threshold. And after reaching this threshold, the risk of myocardial infarction is pretty high. You can see that individuals without FH reach this green line at the age of 55 years, while those with heterozygous FH reach this green line at the age of 35, and people with homozygous FH reach this line at 12 years of age. And when you start treatment early enough, you can reach this line close to individuals without FH. And it's not illustrated here, but it's also true for homozygous FH. If you diagnose homozygous FH early enough and start treatment early enough, you can reach this green line of high risk of myocardial infarction similarly to people without FH. So now you can see the genetics. Individuals with familial hypercholesterolemia have defective genes which are responsible for removing LDL cholesterol from circulation. These are these three genes, and each individual has 2 copies of every of these genes. And if just one copy is defective, this individual suffers from heterozygous FH. So if there are 2 parents with heterozygous FH, they have, as Julia mentioned before, 25% probability that their child will suffer from homozygous FH, which is much more severe than heterozygous FH. If one parent suffers from heterozygous FH and another parent is healthy, the risk for the offspring is 50% that they will suffer from heterozygous FH. There is another situation when another gene is defective, LDLRAP1. This is so-called autosomal recessive disease, where both parents are healthy carriers of the defective gene, and they again have 25% probability of having child with autosomal recessive or homozygous familial hypercholesterolemia. So either semi-dominant or recessive inheritance, the people with FH can have one gene affected or two genes affected, and they can have the same mutation from both parents, or they can have different mutations from the mother and the father. And genetics really matters, and also important if there is some residual activity of LDL receptor. So if there are null mutations, it means there is no residual activity of the receptor, while decreased activity of LDL receptor is present if the mutation is defective. And it's important when considering treatment options, because if there is some residual activity of LDL receptor, you can use drugs which are LDL receptor dependent. But if there is no activity of LDL receptor remaining, you need to use drugs which are independent of LDL receptor function. Now, which are diagnostic strategies? It's very important to realize that early diagnosis is urgently needed, because you can only start early treatment if you know about the disease. So what's recommended, and Julia was already talking about it. If the disease is suspected based on clinical signs or premature atherosclerosis, this is when the testing for homozygous FH should be done, either lipid testing or genetic. So it has already been mentioned by Shirel, if there are signs like this, physician should always consider homozygous FH and should indicate testing for homozygous FH. Because if there is stenosis in coronary arteries, it's too late. Also, when both parents suffer from heterozygous FH, or even not genetically confirmed, but they have both hypercholesterolemia, newborn lipid testing plus genetic testing should be considered and done in their children, even at birth, because then the early treatment can be prepared. So this is this situation when both parents are affected with hypercholesterolemia, and it's the situation when the children should be tested at birth. And what is important at the population level, it is implementation of national screening programs. There is an agreement at the expert level that pediatric universal FH screening should be implemented across the countries. So there is a call for pediatric universal screening in children aged up to 10 years of age. It can be different in different countries because there are different conditions, different medical specialties are involved, different healthcare resources, different geographical and cultural background in every country. And this testing should be based on cholesterol testing, genetic testing, or ideally a combination of both these strategies. And when you find an FH in the child, then you should test also parents, because at least one parent will be affected as well. So combined universal, opportunistic, and cascade strategies should be implemented across the countries. Yes, so we had a pilot project of universal FH screening in newborns, a check-in project. It is an acronym for check cholesterol in newborns. It was a project designed for 6,000 newborns. We measured LDL cholesterol in their umbilical blood. And if their LDL cholesterol was higher than 75th percentile, molecular genetic testing was performed. And we found 16 FH positive children, which corresponds to the prevalence of 1 in 365 individuals. So it was shown clearly that universal screening from umbilical blood is an effective strategy for detecting FH. It should definitely diagnose homozygous FH, so treatment can be started early enough, and it also should diagnose heterozygous FH. And what is very important then, that FH diagnosis can also be done in one of the parents of this child, and also in other family members. So reverse cascade testing will reveal FH in a wider family. So I think this is encouraging, and we'll see if a newborn FH screening will be implemented at the population level. So thank you for your attention.
Thank you, Thomas. But before we move on, I'd like to ask you, what is percentile?
Well, if something is above 75th percentile, it means that it includes all children with LDL, or the highest 25% of population, or 25% with the highest LDL cholesterol levels.
Perfect. Thank you so much. That was really and incredibly informative, and it really brings home how early diagnosis, sometimes at birth, can change lives. Thank you so much. And now we move on to Miranda, joining us from the Netherlands. Now, Miranda, we're so glad to have you here. Could you walk us through your journey? What were the questions, the doubts, the decisions you faced when planning your family?
Yeah, so in the Netherlands, there used to be a foundation called STOE, and they did early detecting in families with people who died at a young age from heart attacks. Unfortunately, this foundation is not there anymore. Maybe something else took over, but I'm not sure, because I was diagnosed, I think, when I was 18. My dad was diagnosed before me, but he was a very fit person, eating healthy, going to the gym 3 times a week. So I was never worried about being diagnosed with FH, really not. And my levels were okay, so I never had to take any statins, any medicines. Only when my daughter was around 2 years old, I noticed little yellow bumps, as you were telling, Shirel. Our family doctor recognized it immediately. But he also told us we never saw that with a child on such a young age. He contacted a pediatrician in the hospital. She also never recognized that with children with at this young age. But I got the advice, keep an eye on it. They didn't know, I don't think they knew about FH or HoFH. I'm not sure. Otherwise, maybe they would have brought it up. And then later, my husband's family was also part of a study from STU, the foundation who detects FH for families. And his mom was part of the study, but she was very keen. She told this lady who took the blood samples, like, my daughter-in-law, she has FH, and her little girl has these yellow bumps. I think it's called xanthelasma. I think. I'm not sure. Anyway. And the lady who did the study was very aware, like, oh, maybe this is a severe case of HoFH. And she decided to test my family immediately. Normally, they wait for the results from, in this case, the mom. But she decided to test my family immediately. And I'm very thankful for that because, we found at an early age that Olivia was affected with HoFH. Yeah. And by that time, my husband and I had 3 children. The other children have FH as well. And we still wanted to have a 4th child. And when we came to the hospital in Amsterdam, an academic hospital, they immediately informed us about the treatments Olivia was going to get. They told us she could start at the age of 6, which was very young that time. They explained to us how it would go. So there was a clear path laid before us. And this gave us a lot of trust in the future. You never know what the future will be, of course. But it gave us confidence that there was a clear path we could take with our child. So what we knew then, she didn't start treatment yet, but what we knew then, and just a team around us, we decided we wanted to have a 4th child. And my husband and I thought about pre-testing, but we decided not to do it. Yeah. So that's our story.
Thank you so much, Miranda. Now, before we open up the floor for questions, and if you have any questions, please write them in the Q&A. I'd like to bring back Julia and Thomas for final reflection. So both of you bring unique perspectives from your work. And while you may not be treating very young children directly, but your insights are incredibly valuable in helping us understand where things are headed. So first, I'd like to start with Julia. Could you share your view on the current recommendations for therapy in children diagnosed with HoFH, and what should families be aware of today when it comes to treatment options?
So I think something that has really changed is we have a lot more medication that is actually safe and that has less side effects than we just had, as Luke just told us, as we just had like 10 years ago. So of course, we have lipoprotein apheresis. This is common in HoFH, but we also have cases where we get around this, where we see people, not only children, but also adults that don't need lipoprotein apheresis, or they need it at a lower frequency because we have such strong medications that are actually very well tolerated. So, and then if we want to treat the children, we have different options. So for the very small ones, lipoprotein apheresis is a thing because you can use it in any age group. But then we also have a very new treatment, which is like an infusion. It's called evinacumab, and you can use it. It was just recently, at least for Europe, it was just recently changed that you can use it from up to 6 months. So just at the end of 2024, you could use it from 5 years on. Now it's recommended to be used from up to 6 months on. I think that is really great. But then you also have the other medications that are also used for treatment of hypercholesterolemia in general, or heterozygous FH, which means statins. Rosuvastatin is available from the age of 6, or recommended from the age of 6 on. Ezetimibe, I think, is from the age of 10. PCSK9 inhibitors, so the monoclonals, meaning also injection therapy now. These are available from 8 and 10 years. So you really have a lot. And then there's also, for homozygous FH, you also have lomitapide. There you have to really regularly monitor liver function, etc. So, but you really have a huge armamentarium. So we are not just looking little children getting their first CABG bypass surgery at the age. You know, this is what we have written in all our textbooks as clinicians. HoFH means CABG at the age of 8. We can really mitigate this risk. Okay, I think that is very important. So, what else?
Thank you. That really give us hope for our future children. So, Thomas, what are your thoughts on how early diagnosis is shaping the availability and implementation of therapies for children?
Yeah, I think it's particularly important in homozygous FH, because you should start treatment as early as possible. And now new options are coming to start even earlier than we used to be. But it is also very important for heterozygous FH, because it was shown when individuals with FH are started with treatment in childhood, they have much better prognosis than their parents who started to be treated in the young adulthood. And the diagnostics is the most specific in childhood. So that's why it's recommended to perform universal screening up to 10 years of age. And the earlier you diagnose a child, the earlier you diagnose one of their parents. And they are at the highest risk of premature myocardial infarction compared to the people without FH, because parents are in their 20s to 40s, and it's the age range when their risk of myocardial infarction is highest. So if you diagnose FH at the age of 2 years or 5 years, it's also very beneficial for their parents, and it's for the benefit of the whole family to have not only healthy children, but also parents.
Yes, so the earlier the better, and the whole family, since it says by a familial genetic condition. So since I have you, I have a question here from the audience. So which, with your experience from a practical point of view with parents, when heterozygous FH is diagnosed, and was it a positive experience from a psychological or other aspects?
So let me see the question. Yeah, I think if the diagnosis is confirmed, the family usually reacts very positively, and they are more susceptible to advice on treatment and to advise for other family members to undergo lipid testing and genetic diagnostics. So if the diagnosis is confirmed, it brings better collaboration from the family.
Thank you. And for Julia, what are some of the biggest misconceptions patients or even clinicians have when it comes to identifying FH?
So I think the biggest misconception I see all day, every day from patients and clinicians is that you can wait with treatment until you see signs of plaque or calcification, atherosclerosis. This is really, I think this is the most important and most detrimental misconception we have out there. I mean, it is about prevention, about staying healthy, and we all want to live like 80, 90 years. Let's do 100. But if you do not treat in heterozygous FH, first event is probably going to happen at 45 around, and with homozygous FH even earlier. So we should not wait. I mean, it's like brushing your teeth. We want to have our vessels clean. We don't start brushing our teeth when we have caries. We do it on a daily basis, and this is what we have to understand. We're not treating lab values. We're not treating LDL. We are treating risk, and this is important. And yes, it's unsexy. Worst case scenario is that you don't see any effect because they stay healthy. So, and then they say, "Oh, I shouldn't have taken the medication because nothing happened to me." Yeah, that's the thing actually. So I think this is the biggest. And second, I will be quick, but I had a patient with heterozygous FH, and she was starving because she was believing that with a low cholesterol diet, she could really make a difference on her LDL levels. So she was quitting on social events like eating pizza with her friends, etc. And because her family doctor recommended you have to have a certain lifestyle. Heterozygous, homozygous FH is not a thing about lifestyle. It's not a thing about weight. It's a genetic disease, and you cannot treat it by just eating well.
Thank you. And I think we have time for a couple of questions. One is for Luke. So looking back now, is there anything you wish you had known at the time of your children's diagnosis?
Well, Julia just phrased it exactly how I would have phrased it about risk, about thinking about when we were starting therapy and the options that were available to us. We had a mindset of let's do the minimum amount or take the minimum amount of tablets or treatment to get us back to a healthy range. If we had have had the mindset of let's have the maximum treatment that is safe for us to lower our risk to the absolute lowest level, I think it's that mindset that really changes your approach to this. Rather than trying to run away from it and doing the minimum, you actually should run towards it and do the maximum. That gives you the best chance of longer, healthier, higher quality living. And if I had have known that probably early on, decisions to go towards therapies that were safe for our children and safe for myself at highest doses that were safe, not just, oh, I want to have the minimum dose of medication to get me back to what the numbers tell me is normal. I would have went the opposite way. I would have had the maximum doses of all medications that were safe for me to reduce my risk to the lowest level.
Thank you. And I have a question for Miranda. So as a caregiver and also as a patient, what helps you stay resilient and informed day to day?
It's mostly the team of the doctors in the hospital in Amsterdam. They inform us about new medicines coming up. They involved Olivia in a study. They explain everything very well. So, yeah, we are just lucky, blessed. That's the word, blessed to have this team. And Olivia, I think she feels the same way. Yeah, she feels the same way. She trusts the doctors, the team, and yeah, they laid the treatment before us. Yeah, and we had, as they explained to us when we came there when she was little, there were already patients, young children being treated, and the way it went, as we heard, we could tell, was positive. So there were positive results already. She was not the first one. So, and as I mentioned, the path was very clear. But to me, FH was not very serious because, I had the example of my dad. So I didn't realize how bad it could be. Yeah.
And we'll hear from Olivia next week in our second episode. So I can't wait also to hear from her. Thank you so much, Miranda. One last question to Julia. So regarding the lack of safety data for lipid-lowering therapies, is this applicable for statins only or all therapies, including recent ones?
No, unfortunately, I just answered in the chat. Unfortunately, for the most medication, it's an ethical issue to give medication to pregnant women and to include them in a study. So this is very, very difficult. We learn from animal models a lot, and then we learn from women that got pregnant and against the recommendation stayed on therapy. So in some cases, some specialists do again start, for example, PCSK9 inhibitors in the third trimester, for example, but this needs to be under expert supervision.
Thank you, Julia. I think with the novel therapies and everything now, with the raising awareness, I think people are more aware of the condition, and hopefully in the future we'll have more data and we'll have more research on that. So thank you all for your questions and for engaging with us today. Unfortunately, I can see there's a lot of questions still, but we're reaching the end of our session. And, due to the time constraints, we may not have been able to answer every question live, but we'll make sure to follow up in the post-webinar email and respond to any remaining questions here. So as we wrap up, I truly and I hope you found today's session informative, relatable, and valuable. And whether you're navigating your own FH journey or supporting someone who is, so this is the beginning, I think. Today's webinar is the first in our trilogy, and we warmly invite you to join us for the next 2 sessions. So episode 2 is on the teenage rebellious, so transitioning from childhood to adulthood. It will take place on Tuesday, June 3rd at 5 p.m. CET. And Alfie is sending the registration link in the chat. And also episode 3 is going to be on Tuesday, June 10th. And we're looking at the future of with HoFH, so living a full life when you navigate HoFH. And one last reminder, the HoFH logo competition is still open, and it's a unique opportunity for you to contribute to the visual identity of HoFH Awareness Day. So whether you're a designer or simply someone who's passionate about the cause, we encourage you to participate and invite others to do the same. And before we officially close, I'd like to take a moment to warmly thank our sponsors and supporters who made this webinar and the entire HoFH Awareness Day campaign possible. So your continued support allows us to raise awareness, to bring families and experts together just like today, and move one step closer to improving the lives of people living with HoFH across generations. So thank you again to our amazing panel, our audience, and everyone working behind the scenes. It's such an honor to share this space with you all. So let's keep this conversation going and have a great night. Thank you so much.